Yes, maybe I am the creep of the health sciences research ethics board. I just noticed we could play on that term. But actually, it will fit well into what I'm going to be talking about. So I'll give you the overview. I'm going to start by talking about some of the conventional approaches to minimizing risk. So I will start there, and Judy Friedland, who's been a very good mentor of mine, actually, who was the former chair of the REB, will be rethinking some of these ideas with respect to risk and vulnerability, so that we can begin to critique, if you will, some of the conventional ways that we've looked at risk. And then we will have Shan Mohammed, who will be providing an example of his doctoral research where he used participants who would traditionally belong to a so-called vulnerable group. And then we'll have some discussion, and hopefully you can bring up examples that fit into what we're talking about. Okay, for those of you who are less familiar with what critical qualitative health research, or if you perhaps just need a little bit of review, I took this right from the website. When we talk about promoting research that addresses the socio-political dimensions of health and questions prevailing assumptions that naturalize health, for example, as individual and biological phenomena. Okay, so there tends to be a critical and political agenda in the kind of work that we do, and there's an explicitly normative dimension to this. And inherent in this, of course, is the hope, in fact, that what we're doing will have benefit to individuals and groups and so on. I mean, that would be inherent in all research, but I think that we make it rather explicit. So that is, on a big scale, if you will, part of the vision of providing benefit. I also took this from the website, where we have our famous onion, the multi-layered complex onion. And I, again, took a small little snippet where we talk about qualitative analysis that can invoke physical and emotional reactions, tears, aversion, appetite, and so on. So in the work that we do, I tend to think of it as being kind of edgy. There's often this closeness, if you will, to participants, their individual lives, their political lives, and so on. And that brings with it, at least in terms of the REB, an element of so-called risk. It also brings about what I would hope for, too, is an element of potential benefit as well. But that's the piece that gets looked at a lot when these kinds of studies pass through the board. Okay, so I'm just putting that aside a little bit as an intro. And then I thought I'd look at the history of research ethics. This is the history of CREEP, if you will. And in a nice overview article by Moreno, he speaks to different stages in the history of research ethics. He begins by talking about the first sort of dawn of research ethics as something formal that happened post-World War II, where he speaks about weak protectionism. This is a time when we began to have more formalized codes of ethics in research, but still the focus was on the researcher and his or her discretion and virtue, as opposed to oversight. So that's where our history was. For those of you who have an interest in the health professions and ethics, it's quite similar there. To what extent we need codes in the health professions versus just virtue, if you will. And those debates went on in my field, I know, in nursing. The specific dates have to do with American history as opposed to Canadian history, but broadly speaking, Canada would follow the same kind of trajectory. We moved into a middle period that ended about year 2000, where we had sort of moderate protectionism, where there was a combination of researcher virtue and external oversight. So the creep began, more oversight, more regulation, and so on. Then we moved after 2000 into a period of time that Moreno calls strong protectionism, where virtue became less important, but oversight, codes, governance, and so on, regulations, came more to control what researchers did. And the emphasis in the literature as well in research ethics tended to focus more on oversight and those norms and rules and so on, as opposed to looking at the researcher per se. So where are we today? There's actually been a little bit of movement back to researcher virtue. And when I speak of virtue, I'm using it in a broad sort of Aristotelian sense, of virtue not just being someone's good intentions, but their skills. And so there's some movement towards what's known as responsible conduct of research. So there's a movement back. I should also say, however, that if you look at qualitative research traditions, I often think of this existing in an alternative universe, in the sense that there's been long-standing recognition of researcher virtue and skill. I don't think that it's ever really gone out of favor. And I know we were talking about it's been 10 years since we've had one of these discussions, and I think partly it's because ethics in qualitative research is not often labeled ethics per se, but it is. It's very much about being sensitive to participants and being careful how we represent data and so on. So there are two very different worlds, if you will. There's the world of research ethics, there's the world of qualitative research, and of course these worlds come together. So back to what could be considered the conventional perspective. This would be in Canada, where we are the guidelines that we follow are that come from the Tri-Council Policy Statement 2, which recently came out with a revised version. I think it was in December, and the 2014 version that has three core principles that I will go into and talk a little bit of how they pertain to risk and vulnerability. The first one is respect for persons, which is probably the hallmark of research ethics, that we need to respect free and informed consent of people in our research. This goes back to a response to what the Nazis did with their research subjects who had never agreed to be in research. But also here you start to see within the text a little bit of a hint, if you will, about what kinds of things we need to be aware of. And those are people who are constrained by lack of information, perhaps they're coerced, perhaps they have a lack of capacity, they're cognitively impaired, or they're just plain young. So these are some of the things that on the REB side that we start to really think about once we start to see these types of individuals involved as participants. The second principle, which is actually pretty straightforward, is concern for welfare. So this principle directly deals with the idea of enhancing benefit, reducing risk, and where as much as possible either mitigating the risk or eliminating the risk. And again, going back to sort of REB activity and perhaps researcher activity as well, I often think of this activity involving one's moral imagination, if you will. If you start to think about what kinds of foreseeable risks, what could happen to this participant. So you see a lot of what-ifing. I think it helps to have a reasonable dose of neuroses, too, to start thinking about, what if this happened, what if that happened? And you can start to see the conversation going on and on and on and on. And so you kind of have to go down that road until it becomes ridiculous and the risks that one is assuming might be too far gone. But anyway, so this is the second principle. The third principle, I think, fits in very well into CQ endeavors. There are some very enlightened passages, actually, in the TCPS2, where there really is a recognition that there are vulnerable and marginalized groups in society, that they need special attention in research, they need to be adequately protected and treated justly. But the important point being they're not to be excluded from research either. And Judy will be talking about this more in her section about not overstating risk. Okay, vulnerable groups, people and groups. Again, some REBs actually, and Judy will talk about this, have lists of groups of people who are designated as vulnerable. U of T does not, as far as I can tell in any of the documentation I've found. But in the TCPS2, there are certain groups that are highlighted because of for historical reasons. People who have been abused perhaps in research participation, prisoners, minorities, people with mental illnesses, and less capacity for self-determination. And also people who, for whatever reason, have been disenfranchised in some ways and haven't had access to some of the social goods many people have. So those would be considered vulnerable, again, where more attention would need to be paid. Risk also is very specifically defined with two key components. One looks at the magnitude of the risk or the potential harm and the probability of this happening. And this can be anything from risk, from anything from death to inconvenience. But on the CQ side, or the type of research we tend to do, we often worry about political risks, maybe emotional risks, perhaps the loss of reputation, and so on, which is a little more tricky to determine. If you, for instance, if someone were doing a drug study, they may be able to point to research evidence and suggest these are the likely harms that could occur if someone were to take this drug and had an allergic reaction or something. What's much trickier in the kind of work we tend to do is that there's a very small body of research evidence, although it's growing, that actually has researched what it's like for people to participate in research. On a happy note, for the most part, that research is indicating that most people, even if they're initially stressed, don't have long-term harms, generally speaking. But it is very difficult to sometimes make an evidence-based type of decision. Another thing that I find interesting in the TCPS2 is that it tells us that researchers and REBs, and I've highlighted this, should attempt to assess the harm from the perspective of the participant. So again, one can try to use one's imagination, which is always extremely limited, to try to think about what would it be like if I were perhaps a homeless youth or something like this. Or it can come from the researcher who may have a great knowledge of a particular population. So this is what we are asked to do, and as much as possible to turn to the limited but still existing research evidence. All right, I thought I'd give you a little overview again of the U of T risk matrix. Most of you have probably seen this. We use this less than perfect matrix to determine whether or not something should go to delegated review or to full board review. So if you're at a 1, it's delegated, which means there's not as much attention paid to it. Of course, every researcher wants that to happen. Fewer eyes, fewer comments. Or so-called 2 or 3 types of risks. So again, there's an attempt by the researcher to indicate whether the group is low, medium, or high in terms of vulnerability, and to what extent the research is risky. So if one is asking very probing questions, or there's a high risk of confidentiality being broken or something, the research risk becomes high, and then you look down the matrix to find where in fact you exist. Some of these, and some of you maybe have experience with this, sometimes the studies that go to delegated review get bumped up by the reviewer. So that happens usually once a month. Okay, so that is the U of T perspective, and I'm just going to end by a quote by MacDonald and Cox, where they also speak about much of the research, or they say discourse, has been focused on these things like norms, rules, regulations, and so on. But we actually don't know very much about whether or not REBs are in any way effective. Are they actually protecting people from harm and risk and so on? And they speak very much about needing a lot more research evidence to guide the practice of REBs. So next we have Judy Friedland, who's going to begin to sort of problematize some of the standard viewpoints.
Thank you, and hello everyone. I'm going to sort of try to unpack this concept, which is way more complex than one thinks. I mean, I thought, well, this will be kind of fun. I can look at this in a few different ways and so on. And, I guess as happens with a lot of knowledge, the more you delve, the more you find. And that little onion that you have is not big enough. And furthermore, it's a red onion that's so small. I've never seen a red onion that small. So I don't know, it's just...
Blown it up.
You could have, yeah. So just to start with, a little bit of basics around the term vulnerability, coming from the Latin word to wound, something that we, of course, don't want to do with any participants in research. Being vulnerable, the Oxford Dictionary talks about being exposed to the possibility of being attacked or harmed, or either physically or emotionally. And for the Council of International Organizations of Medical Sciences, looking at the idea of being substantially incapable of protecting one's own interests. So that's quite a different slant. And I guess we would be going further in terms of research ethics of saying, how can we effect a greater protection of that individual's interests? So as Elizabeth has mentioned, some of the implications of vulnerability is, the first thing is that it really does trigger the REB to have a look and see whether these participants really can be protected or if they should be protected. And I just tell you a little anecdote. I remember a number of years back when, as Elizabeth was mentioning, and you'd all know, we have full board review of protocols and we have delegated. And we seem to be just getting so many delegated protocols and not as many full as we would have liked to have had and thought we should have. And knowing also that one pair of eyes, the one delegated reviewer, is not going to pick up and catch everything, we started going back looking at applications just to see who's that population. So, and then it triggered in your mind, that list. Are they elderly? Are they children? Are they mentally ill? Are they, et cetera. And as soon as that popped up, we asked our coordinator to say, take another look, and let's make sure this really should be delegated or should go for a much more detailed examination. And of course, one could expand the definitions of vulnerable greatly. I mean, where do you stop? But the point is that there's a level of scrutiny that will occur when vulnerable populations are going to be studied, and the researcher, I think, needs to be fully cognizant of this, and I'm sure is in most CQ research. So there's also a concern that there might be vulnerable groups that are in fact being exploited and will lead to there being no approval whatsoever. I mean, that there might be a sort of a hard and fast rule within the organization, the REB or whatever it is, that really these are untouchable groups. And it's not so long ago, if you think back, where a lot of groups were being protected. I can remember where HIV with women was a very protected and narrowed, in order to access populations of women with HIV was very, very difficult. Institutions like ours at the University of Toronto are risk averse, and we at U of T are no exception. The university tries to protect itself against risk of financial risk, obviously, legal risk, certainly, which could also be financial, and reputational risk. I guess we have all of these going on across the road with the picketers at this moment, that U of T is, going to have a lot of publicity about what's happening now with the strike that's going on here. But this idea of being risk averse naturally seeps into the REB, and the board has to consider the risk that might accrue to the university depending on the research. So we really, in some ways try to offload the idea by saying, okay, if it's really free and informed consent, then the individual is the one who's taking the responsibility. But, how do we really know how free that consent is? How do we really know how informed it is? I'm going to speak about this again in a minute, but very few consent forms ask individuals to talk about what they know the study is going to do. In other words, we don't ask for that feedback after we gain consent to say, now tell me in your own words, what do you think is going to happen? And to ask a set of questions even, or at least a couple of questions, that really determine whether the person is informed. We go through this whole thing and someone signs, and sometimes people even want to witness as if that's going to make it okay, and it doesn't necessarily do that. Of course, the idea of considering vulnerability in relation to the research itself, issues of power differentials between the researcher and the potential participant are also very complicated. So in terms of trying to pin down the concept, these lists that develop should increase researchers' awareness of the harm. So it's useful to a researcher to say, okay, am I working with any of these groups? We neglected to mention that where I am now is at Public Health Ontario, and I have two of my colleagues here with me today chairing that ethics review board. And in our list, we talk about groups that will be harmed in terms of outcome, or have the potential to be harmed in terms of the outcome of the research and how it's disseminated and what happens, as well as within the context of the research itself. So here's just some examples of institutionalized individuals, people engaging in illegal activity. We had that case just this past year. This finally sort of wound down about that. What's his name? Who did the? I'm holding my neck. The dismembering. What's the? Magnotta. Thank you. Groups that are potentially in stigmatizing conditions or activities. First Nations, Inuit, and Métis people, a very interesting other category in the sense of not that they're necessarily so vulnerable, although there's been a long history with them of difficulties, but their issues of needing control over what their data and what's going to happen with it and so on, which is a great thing, actually, when you come down to it, and more groups should be emulating that, and so on. So, and I think one of the things that's always an issue for us in public health is, research needs to be done to identify groups and communities that are underserviced or suffering in some way, but when you then disseminate that information, what is that? How do you handle the potential for stigma and so on? So lists aren't inherently bad. It's really more a question of, what happens with them. There's been lots of other interesting attempts to categorize. This one by Kenneth Kipnis in 2001 has a set of, I think it's 7 analytical categories. And the idea is that if any one of these fits your population, then you need to sort of really have a much closer look at how you're going to be handling this research. They're probably all fairly understandable just by their labels, although the word juridic threw me, so I'll read you what that says. It's liable to the authority of others who may have an independent interest in that person's participation. So the third party giving permission, I guess, in that case. So that was an interesting one. It's interesting to think, though, that that's 15 years ago that list was set out. Some more attempts to categorize that the idea that vulnerabilities may be inherent, that's universal for all of us. They may be situational, sitting here, in this room and being told now that you're going to be examined on everything that we're saying would be a situational vulnerability at this moment, or pathogenic, the idea that in fact there's something in terms of the situational vulnerabilities that occur because of adverse social phenomena. For example, some injustice, some disability group that is in the power of incompetent caregivers and becomes worse off or something. That would be considered a pathogenic vulnerability. They can be occurrent, ones that are very likely to happen, or dispositional, very just potential outcomes. Vulnerabilities need to be considered in terms of the research participants, which is who we always are thinking about, but we always need to think as well about the research team and the research process. And I guess most people will be most familiar with the research team issues when we're talking about student researchers and how well protected they are when they're going out in the field, and how adequate the supervision is, and or the situation into which they're entering, perhaps in a foreign country, for example, and how difficult that can be, as well as the whole process of the recruitment, the sampling, the invitation to participate, and so on, and how we can exacerbate or not the vulnerabilities of individuals. So the question that Elizabeth raised about does any of this protection work? Well, we really don't know. We don't know very much about if we weren't offering these protections, would the situation be any worse? And so that's a huge area for research that should be done. What's really interesting, I think, in all of this is that individuals are rarely asked if they think they will be vulnerable in a research situation. And this is now going to be really exemplified in Shan's presentation. But, we have this mindset that, this is a, quote, vulnerable population, and yet no one asks me whether I feel vulnerable if I'm talking as an older person about my medical condition or something of that sort. It's decided sort of a priori by the research team, by the REB, and so on. Smacks of paternalism. With this focus, the research continues also to emphasize the notion of vulnerability as opposed to the notion of resilience. And I mean, that's not really an ethics issue. It's a research issue that as researchers, we don't do enough to look at what makes people survive as opposed to what's giving people problems. One of the studies that I looked at, well, I'll come to that in a second. So shifts are certainly apparent out there from this idea that we know everything about our participants to seeing participants, from seeing participants as a collection of providers of data. We've fortunately gotten away from the term subjects to at least to participants, but you'd be surprised at how often that creeps in. And it's funny, it would be an interesting study to think when it does creep into an application to know whether we look at it with very different eyes, because it's sort of telling us that that researcher is looking at their study as that this is a collective body of people to be studied as opposed to human beings with other sensibilities, and to seeing them as, in fact, active participants in the research process. So this idea of shifting a bit from the REB and the researcher making these decisions to the participant is a very interesting shift that's beginning to occur, it seems. Well, there's lots of very general mitigation strategies, because I would say another sort of trigger on an REB would be when a researcher says there's no risk. Because I think we all, sitting on these boards can always find a risk. and I don't think that's just because we're crazy, people, but, and a bit obsessive, although we could do that. But I think, it's hard to predict. I mean, just the very fact of that you don't know really what's going to happen out in the field. I mean, you've got all this plan in your research protocol, but you've got so many unknowns about the individual doing the interviews, about the recipients, about the weather that day, about whatever, that there are many unknowns. So it's very unlikely that there's no risk. It's much better to try to identify the risks and let the REB know what you think might be the case, and then move into whatever mitigation strategies you can think of. One of the best ways is to not try to think of them yourself in a vacuum, but rather to engage others in helping you do so. So engaging key informants in your design, having a community advisory council is really important. Doing participatory action research is a way of really protecting that's somebody supporting the strike, yeah. Doing participatory action research would be another way of kind of ensuring that you've got people on board and having a bit more sensitivity. Doing a pilot study to see how this is playing out. You thought it would be an easy survey, no one would get upset, nothing would happen. See whether that's true. Simple things of changing formats from, for example, focus groups, which are, I mean, they have their benefits, they have their place, but in terms of risk, it's so uncontrollable about what will happen in that group and how, pardon me, group members will respond in terms of confidentiality and so on and so forth. And we can say all we want, and don't put anybody's name, don't mention anybody's name, or don't mention an institution, or we can say we're going to redact that when we see it, and so on, but it's out there, and it's not as controllable as it is in an interview situation. I sort of highlighted these last three items because I think they're really important that we haven't really spent much time on. One is enhancing the skills of the person, whether that's an RA or whoever that's interacting with participants. We've so often sent people out with about a modicum of preparation to doing this kind of work. We don't have much oversight on the research process. U of T, some of you might know, has just started, it's not called an audit process. What's it called now, Elizabeth? It's a much watered down term. What is it? Sort of.
I know they're visits.
They're visits. Like the word visit is much better than an audit, right? But the idea is it is time for us to start looking at how does what you really did compare to what you said you were going to do? And, what does this tell us about any of this? And maybe somewhere down the line to actually getting to participants and asking them what they think. And the other thing on this list that I would encourage is enhancing the available resources. When again, it's another throwaway line. There's a risk of psychological distress, and your mitigation strategy is going to be counseling, and handing out a list of counseling resources. Is a list really good enough when somebody is really upset? Is the resource going to be available 24/7 if in fact that's necessary? Or going back to the training of the person being involved with the participant, do they know enough to really recognize when that person is at risk and needs the help? So it's really a complicated thing. One of the solutions that I think has been often offered, and actually, Elizabeth, you were, I think, referring to this a bit when you were saying, as CQ researchers, you have an innate sense of being in a good position with the people you're studying. So the idea that clinician researchers generally can have, and I'm not saying CQers are clinician researchers, but that they would have access to gatekeepers and hence to populations that they need, that they will have clinical expertise that they can use during sampling, during recruitment, in those interview situations is a real positive, or can be considered a real positive. But it also can be considered as a problem because these researchers may be too close. They may have difficulty with boundaries, and I know we could talk about that as another whole issue. Maybe there shouldn't be boundaries, etc. But at some level, there's going to be some boundaries, and that may be a difficult thing. And perhaps more importantly, in that relationship, good as it may be, established that really brings out the rich data that we're looking for, that could also have the downside of, or the risk, I should say, of making the participant anxious about withdrawing from the study, anxious about saying anything negative about the study, complaining in any way. So again, not a simple solution. One paper that I read, actually by people in the nursing faculty, Heifner and Knapik, talked about ethical mindfulness. And I thought that was a lovely expression and nice discussion about being able to identify ethically important moments when you're meeting with someone, making sure that you give credence to your own feelings of discomfort. And again, I know Shan's going to speak to that. And really, we talk about being self-reflexive and so on, but being ethically reflexive. I mean, trying to put on that hat and balancing the idea of getting close to participants, but with maintaining some distance in order to also maintain some sort of methodological and ethical rigor. Another area being referred to in the literature is about sensitive research, and I suspect this is what a lot of CQers are doing, where you are clearly working with a vulnerable population. There's no guessing about that, and about sensitive issues. And a lovely study that I looked at by Kylie Aglias, was about family estrangement and interviewing elderly people about the estrangement of family members, and the panic about how are they going to get that through an ethics board, and how are they going to get the results that they're looking for, or they just having that discourse and so on. And of course, I mean, we all know, if I ask you to guess how that worked out, what would you say? What would you say about a study like this? I mean, asking elderly people to talk about members of their family who have been estranged from them. Do you think those participants would feel what?
I think it would depend on their cognitive status.
Well, they're assuming their cognitive status is okay. Sorry, should have said that.
Well, often they do want to talk.
Exactly. I mean, and I think we all know that, and yet somehow there's that thing out there that says, panic, don't ask these questions, go to this population, and so on. And they talk about orienting the research away from the pathology and toward the participants' resilience and their capacities and promise and so on, and suggest an assessment of the individual's strengths when you're looking at vulnerability. So not just what the problems are, but what are their supports? What are their self-care mechanisms? How are they looking at this being oriented to the project or to the interview? What sort of survival skills would they anticipate using? So that gets back to yet another way of asking questions of potential participants. Not only do they understand what's going to be asked of them and what you're going to do, but how do they think they'll cope with it and can manage? So I'm going to conclude with just this to say, naturally, this onion has lots of layers, and there's still many, many questions. One of which is, do we need to expand the protections that we already have, that TCPS provides for us about respecting persons, concern for welfare, justice, etc.? Or do we really just need to apply them in a much more vigilant and accountable way when we're concerned? And one that I guess comes to me more from my public health work than anywhere else is about identifying and reporting needs of vulnerable groups without stigmatizing. There's just a very difficult road there, I think, to make sure that happens in the best way possible. The bottom line question about can we protect participants and allow them to have their own decision-making, autonomous capacity. I mean, it's almost like an oxymoron that you're going to protect, but they're going to be autonomous, So how does that work? And finally, I would say, what do study participants think about all of this? And it's time we asked. Thanks.
So before I begin, I have to say I'm new here. Is anyone else new here? Meaning, are you a PhD student? Did you recently graduate? Can I see a show of hands? Only one person. Okay. So in this part of the seminar, I'd like to present an example of a recently completed doctoral thesis, and I completed it about a year ago, to initiate a discussion of how new researchers might navigate the complexities of risk and vulnerability through the research process. So I'd like to begin by introducing my doctoral work. So I conducted a case study on people with cancer and their search for life extension through biomedical treatment. And I drew upon the work of Michel Foucault, so I did a critical analysis as my theoretical perspective, and I was interested in characterizing the types of discourses that constitute the search for curative treatment, and also the types of subjectivities that were shaped by this discourse. So in other words, I was interested in looking at how patients with advanced cancer utilize power-knowledge relationships to locate treatment, and how they shape their own actions, perceptions, and thoughts to become people who can generate their own curative possibilities. So as part of my data collection, I collected 7 cases that were collected around one patient with advanced cancer who was seeking or actually receiving curative treatment. And then after that, after I interviewed a patient, I asked them to refer a family member or a healthcare professional that was influential in their search for treatment. And I also asked participants to identify what types of books, websites, magazines they were reading. So the recruitment site for the study was an ambulatory palliative care clinic within a large comprehensive cancer center. And the data included 30 documents, 20 interviews, and about 5 hours of observational data. And I interviewed a variety of people. So I interviewed patients with advanced cancer. I interviewed family members, spouses, siblings. I interviewed oncologists. I interviewed palliative care physicians, oncology nurses, and I interviewed one natural healer. I just want to talk a little bit about the diversity in the sample. So the sample had some diversity. So participants with cancer range in age from late 30s to early 70s. 4 were men, 3 were women, and they were originally from a variety of places around the world. And the cancer demographics were diverse as well. So individuals had prostate, breast, hematological, pancreatic cancers. And participants had cancer for about 1 year to several years following a remission. And people were getting a variety, or looking for a variety of treatments. So people were getting or looking for experimental drug trials, hormonal treatment, experimental radiotherapy as an example. And in addition to receiving or looking for conventional medicine, people were trying things like positive thinking, mind over matter, alternative therapies. So the search for treatment wasn't just related to the biomedical, it encompassed more than the biomedical. So, I mean, Elizabeth talked about neuroses, and, I think that, I'm number one neurotic, and, I think this is part of the process of becoming a researcher and a part of the shift from clinician to being a researcher. And there's much written in the methodological literature on palliative care and end of life about people with advanced cancer and their vulnerability. I do have to say that I'm an oncology nurse, and I've worked clinically for about 8 years or so. So I do have extensive clinical background in working with this population. But there was much to navigate when collecting the data. People weren't well that I interviewed. People had many cancer and treatment-related side effects: pain, fatigue, immobility, nausea. And I interviewed people in their home, them and their family in their home. So this added another dimension of risk and vulnerability, if you will, because I didn't have a luxury of having the patient first screened by a healthcare professional, for example. So it depended on how people were feeling that day when I showed up to interview them. So you really didn't know. The other thing that I had to do while collecting data was to very carefully navigate the emotional despair of patients and family. So I remember interviewing a woman, and they interviewed her partner right after in the home. And before I kind of ended the interview with the woman, she said to me, I just want to let you know, just take it easy. Take it easy on my partner before you interview him, because he's really struggling. So these are all things to consider as part of risk and vulnerability when collecting the data while you're doing it. And much has been written, and Randall and Downie talk about the sensitive nature of death and the idealization of care for those who are dying often preclude a critical examination. So there isn't a lot of critical research on how we care for people who are at the end of life from their perspective. There's another body of methodological literature that suggests that people who have terminal illness may not derive long-term benefit from their participation because they're dying. So this idea of risk and benefit complicates it a little bit. At the same time, there's another group of literature that suggests, and this group of literature has interviewed people who have terminal illness about their experiences participating in qualitative studies. And it suggests that many people who participate, who are at the end of life, actually find it very meaningful and very helpful, and their willingness to contribute to the scientific literature despite their severe disease. So as I mentioned earlier, I recruited through an outpatient palliative care clinic within a tertiary care cancer hospital. And I have to say that from my experience, generating buy-in from the clinic staff was very challenging because of the perceived risk of this study to the population. So as part of my recruitment strategies, I attended monthly meetings with clinicians to explain the study and also to possibly review the clinic lists to see who would be a good candidate to participate or who wouldn't be a good candidate. And depending on what they suggested, they would approach the candidate first, and then I would follow up. Many clinicians that I observed were very protective of patients, highly protective, and gatekeeping became a very real challenge. I noticed that many of these clinicians formed previous bonds with these patients and families. I could appreciate that being a clinician myself. I'm sure that some clinicians were concerned that patients would critique them or call attention to their care that they received in interviews. And from my experience, the clinicians in the clinic I recruited from weren't hesitant to share with me their concerns about the study. So they told me, time commitment, they were concerned about burdening the patient, they were concerned about emotional distress. And as a doctoral candidate, I learned many lessons about risk and recruitment. So for example, when I was explaining the study, I used the term rationale. So I said, I'm interested in learning about the rationale of people to choose particular treatments, which is a postdoctoral term. But clinicians didn't get the word rationale. That caused them a bit of distress. So I remember presenting at an interview, and I really reflected on how I sold the study, too, during recruitment. I remember going to a meeting, and a clinician told me afterwards, well, I don't think you're interested in rationale. I think you're interested in experience. And I think it's better for you to say I'm doing the study to look at the experience of people searching for treatment, which is interesting. But I did generate buy-in, which was challenging, but it involved an ongoing continual relationship with the clinicians. I often presented, or often told clinicians that the previous participant really enjoyed participating in the study, and as your patients would as well. But it was tricky. Well, I often relied on my clinical background to navigate the emotional terrain of interviews. And it was interesting to me how people wanted to perform their subjectivities as a social performance during interviews. So some participants wanted to convey that they were managing their cancer great. Some wanted to say that the treatment was just fine for them. And they wanted to kind of show this to me as a social performance during data collection. I remember one participant who was with his wife telling me, ask me anything. I can handle it. Just ask me anything. And, he was visibly upset. So how to very carefully probe and move back and navigate. And I really relied on my clinical skills, but it wasn't an easy thing to do. It was actually quite challenging to do. Since I collected cases in the study around a participant with cancer, this led to certain challenges building the case, in particular generating referrals to healthcare professionals. So some participants were very hesitant to refer their nurse or physician. Some were fine, but some were very hesitant. And it seemed, on analysis, on reflection, it seemed that some of these participants were maybe concerned about destabilizing their current arrangements that gave them access to treatment. There was also many challenges consenting observation, and almost all participants were very hesitant about me attending clinical appointments, possibly because of confidentiality, but also potentially, again, because of this concern with destabilizing their current arrangement to treatment. So in this slide, I just want to talk very briefly about the results of my findings. I found that the search for life extension generated multiple discourses and several active forms of subjectivities. So in other words, people with advanced cancer reshape their actions, perceptions, bodily practices, and so forth to become subjects that could generate their own curative possibilities despite having a terminal disease. The sense of activeness transferred into how participants told their story. So again, this idea of problematizing vulnerability. Participants told their story with an incredible sense of vigor. And interestingly, for me, I had to limit the level of participation for some participants. They actually wanted to do a third interview. They wanted to have an ongoing conversation with me, even though it didn't fit into the REB protocol, and even though I felt like it was kind of overstepping research, bounded research relationships. So I found that I had to end a research relationship with people as opposed to kind of, initiating it. I struggled with ending it, not initiating it. And McCabe Holmes writes about how, for many participants, research can be a welcome space where one can explore different and often controversial perspectives, often with less judgment than the outside world. So to give you a little flavor of the data, in my analysis I identified something that I called the proactive subject, so who searches for their own treatment and often applied an entrepreneurial spirit, if you will, to the search for cancer treatment. So this is a great example of a quote. If you're not proactively looking at different situations, you make the treatment less effective. If you totally rely on what the hospital offers you passively, then you maybe only get 70% of the effect. I want to get 99%. If I can do anything to help, I'm the one who benefits. That's my philosophy. I just see it as a business venture. You maximize your profit, right? So I did talk about the diversity of the sample, but one area where the sample wasn't so diverse was socioeconomic and educational background. So this calls into attention this idea of risk, power, and reflexivity. I interviewed people that were fairly affluent. One person I interviewed in their house had their housekeeper bring me tea, as an example. There was still this notion of my own power as a researcher and healthcare professional, but In other ways, my experience collecting data decentered conventional ways of thinking about power-participant differentials. At the same time, I was still constantly aware of how power relations were circulating throughout the research process, which is a very important consideration to postdoctoral research. Of course, I became aware, and Judith talked about this, of my own positionality, so my own social identity as a clinician, and also somewhat the family history of cancer. So this brings up the notion of the researcher as a co-creator of knowledge, and also what Patton describes as reflexively shaping the self through the research process. But what was really interesting was this notion of vulnerability and my own vulnerability as a researcher. So I remember interviewing a natural healer, and this person wanted to share photos of themselves after doing some sort of alternative treatment on their skin. And they wanted to show me actually a photo of a very intimate part of their body. And her rationale, her justification was, I know you're a nurse, therefore I can show you this. But the interview had ended. It was actually very upsetting to me. So I did have the benefit of having a wonderful research committee to talk it over. But I think this idea of risk and the researcher is also something that we need to probably conceptualize a bit better. Thank you.
Yeah, we just have a couple of things to think about when we go into this sort of question period. One that I brought up was the lack of evidence, despite the amount of emphasis that goes into regulation and so on. And also, I think what Judy brought home very well is the vulnerability is a really complicated concept, as is risk. And that we don't actually sometimes know what the difference is between, let's say, the researcher and the RAB assumptions versus the actual experience, if you will, of participants. And I think Shan brought out some really great examples of that many of our assumptions, and I know when we work together, were actually quite overturned. So, and if there is any way of concluding this presentation with its multiple facets, I think that the take-home message is more that mitigating risk is more a function of researcher skill and virtue, and the emphasis needs to be placed back onto that. We have a couple of questions in case there's not a question that comes to your mind. If not, freely ask questions or comment. So we will return to the front then.